Thank you once again for having me. We had a wonderful time during the first session on identification of pediatric sepsis. And hopefully today's session, being a follow-up, will be an interactive one as well. So I would be looking forward to comments and contributions from all of us. Okay. We'll be looking at the management of pediatric sepsis. And as introduced earlier, I'm Dr. Eugene Kwekumate. I have no disclosures to make. And this will be the outline of our presentation. And I've also structured the learning objectives to follow that. So by the end of this session, I'm expecting that all of us will be able to recognize and diagnose pediatric sepsis early. And I believe this objective has been achieved from our previous session. We want to be able to implement timely initial resuscitation with emphasis on goals of the golden hour of sepsis. Also, to be able to safely administer fluid therapy, initiate and appropriately titrate vasopressors in our patients with sepsis, appreciate the role of steroids, institute supportive therapy, prioritize source control, and then be able to monitor and reassess progress as well as effectively communicate and document. So this is just a recap, just to stress again that for pediatric sepsis, the diagnostic criteria as we have it now, a lot are leaning towards the Phoenix sepsis criteria. However, we would still like to maintain initial SES criteria as a top layer or screening tool. And then you can further go on to apply the Phoenix score to the patient. Okay. So I'll begin with a case. You receive a consult from the surgical ward and you are the resident doctor in the pediatric emergency unit. So I would use PEU from now onwards. There's a 10-month-old infant, MM, who has undergone exploratory laparotomy with bowel resection and ileostomy on account of ileocolic intussusception. On post-op day 8, you receive a distress call for transfer to the pediatric emergency unit as she has become febrile, increasingly lethargic, in respiratory distress, and the team is having a hard time gaining venous access for this child. So on your assessment, these are your findings. You found the airway to be patent and maintainable. Child was in respiratory distress. The rate was 50 cycles per minute, saturation of 92% on non-rebreather mask at a flow of 15 liters, which puts our FiO2 at approximately 80%. Had adequate air entry bilaterally with no added sounds. Had cold, clammy skin, cold extremities, and capillary refill was 6 seconds. The brachial and femoral pulses were weak and thready. The heart rate was 180. Your blood pressure is 60 on 25 with a mean blood pressure of 32. The liver is not enlarged. Child is conscious but lethargic. There are no lateralizing signs, and the child's RBS is 1.6 millimole per liter. Temperature is 38.6 degrees Celsius. Child is moderately pale, anecteric, not dehydrated. You found the abdomen to be distended and tense. There's no effluent from the ileostomy, and the urinary catheter, which is in situ, only has very scanty. So my first question is this sepsis or not sepsis? You can type your response in the chat or you can unmute and comment. And then justify why you think it is sepsis, if you think it is sepsis.
So what do you think? You're free to write it in the chat and I will read it for you.
I'll just wait about 30 seconds for responses and then I'll move on.
Try to use maybe a score so you can have an orientation that could help.
Yeah, it is sepsis.
Okay. Yes, I agree it is sepsis. So
It's
if you use
sepsis
the 10
because
criteria, you
if
meet the
if
diagnostic
if
criteria
you
for sepsis.
if you
And then if
apply
you use
for
the pediatric
oh,
sepsis, sorry, the Finnish sepsis score, that also qualifies as child to have sepsis. Okay, so then again, my next question, what complications or emergencies can be identified in the case? So for the purposes of the discussion, I'll just go back to our assessment and then try and see if we can pick out all the danger signs in this child. Any comments so far?
Okay, so we have a comment from the chat. So Gemishu Ede say this child is septic because febrile, delayed CRT, motile skin, and hypotensive. Another
Yeah.
commentary is anemia,
Okay.
hypoglycemia, and shock.
Okay. Great. Any comment on the respiration? So yes, this child is in respiratory failure, is in distress and has become lethargic. Okay, so without your blood gases giving you a fair idea of what the partial pressure of oxygen or carbon dioxide is, you could fairly say that if you have a child with respiratory distress who has altered level of consciousness, can be as subtle as being lethargic or irritable, you can safely assume there's respiratory failure. If we apply the SF ratio for this child, that's 115. So even though we have a saturation of 92, you can clearly see we are expending a lot of energy and using a lot of oxygen to achieve that. And that puts the SF ratio at 115. So that would be severe hypoxemia for this child. Child also has septic shock. So you can find all the parameters. We say that per the Finnish sepsis score, if you have a score of 1, at least in the cardiovascular assessment, then you qualify for septic shock. Child is hypoglycemic. The child has anemia. You're also concerned about the tense abdomen with evidence of organ dysfunction. So this child is in shock, has respiratory failure. It's not passing urine. So you're also concerned about possibility of abdominal compartment syndrome. And the child also has acute kidney injury. Okay. So for our second learning objective, how do we implement a timely initial resuscitation with emphasis on the goals of the golden hour of sepsis management? Okay, so I would like to hear from us before I give my opinion. If you have a patient like this, what will be your initial steps if you have this patient in front of you at the emergency unit or even on the ward?
I think your approach will also be determined by some logistical issues, like if you are in a far rural primary health district, and it's different from when you are in a clinic that is next to a tertiary center. But the basics will always remain very important, like making sure you raise you correct some dysfunctions like low blood pressures by giving fluids, giving vasopressors. So I think that will be the approach.
Yeah. Thank you for that wonderful contribution. And I agree perfectly with you. So irrespective of where you find yourself and the resources available to you, there's always something you can do for the child who is in trouble from sepsis. Okay, so remember our golden R, you want to be sure that you are recognizing or diagnosing the sepsis early. You want to quickly obtain IV access and take your sample for lactate and blood culture, and then initiate intravenous antibiotics and then IV fluid resuscitation if indicated. Okay, so at least these are the basic things that you would want to do. Okay, and then we'll add on to that layer as we progress. Okay, so for a resuscitation, you can always be guided by your ABCs. So for the airway and breathing, okay, for the child who has mild hypoxemia, okay, or has increased work of breathing, okay, you can give oxygen via nasal cannula or a face mask. Okay, if the child has moderate distress and the hypoxemia is persistent, if you have availability of high flow nasal cannula, you can apply that as well. If the child has severe respiratory distress and you begin to get worried about the declining SF ratio, okay, if you have access to non-invasive support, okay, and I know for a lot of us, we are able to do improvised bubble CPAP. If you're able to do that and your child is less than 15 kilos, or ideally less than 10 kilos, then that's an option to consider for the bubble CPAP. Okay. The essence is for the child in shock, remember that even though your saturation may be okay, delivery of oxygen at the tissue level is still suboptimal. And we know that oxygen delivery is dependent on your oxygen content and your cardiac output. So any way you can try and improve the oxygen content will go a long way to assist this child deliver oxygen at the tissue level. So for your child with sepsis, you always need to assess and ask yourself, do I need to give oxygen? Now, for some of your patients, they may have refractory hypoxemia despite your initial interventions. If they have altered sensorium, unable to protect their airway, right? For a child who is already bradypneic, the child who is already going to respiratory arrest, those children, you have to take an early decision to intubate if your facility has means of providing mechanical ventilation. I must, however, caution that two things. You want to be very, very, very careful giving excessive oxygen, as our septic patients already have elevated levels of inflammation ongoing in their body. If you give too much oxygen, then what you're trying to do is amplify formation of reactive oxygen and nitrogen species. And that in the long term may be harmful to the patient and may give you poor outcome. Also, if you are using positive pressure for any of your patients, you have to also be very cautious, especially for your patient who is in septic shock, as very high positive pressures may end up reducing venous return and compromising your circulation. So you need to pay attention to that as well. And just like one of our participants contributed, sometimes you are restricted in terms of resources. And in some cases, imagine you have this child with you who is breathing very slowly. The effort is poor. Your oxygen is not improving with whatever delivery device you have. Sometimes you may actually have to support the patient with bag mask ventilation until you are able to get the patient to a facility where they are able to provide the needed support for this child. Okay. So we move on to circulation. And for that, you would want to quickly obtain IV access. And I must say that you shouldn't spend 2 to 3 attempts, not more than 2 to 3 attempts, trying to get a peripheral access. We've had instances where people may spend 30 minutes and are trying to get an access for a child who is septic and in septic shock. So always remember that the intraosseous route is an alternative. So within a minute or two, you are not getting an access. It's an emergency. Every minute that passes would increase mortality for this child. So don't spend all the time trying to get a peripheral access. And once you do, please get a sample for blood gas. You'll be interested in your lactate. You definitely need a blood culture, and then also any other adjunctive lab as indicated. So that will depend on what the patient presents with. Okay. Once your access is obtained, you want to give broad spectrum antibiotics. And I must say that this should be guided by where you suspect the source of the infection may be, the usual organisms that are noted to cause infection in that source. Does the patient have comorbidities or organ dysfunction that might require you to revise your choice of antibiotic? For instance, you may want to give an aminoglycoside, but the patient may have a renal injury, and therefore that may probably make you more cautious in going for that alternative. If another alternative exists, then you may probably want to look at that option rather than go first with your aminoglycoside and the patient already has AKI. And then, of course, you will be guided by your institutional protocol. If your patient has septic shock, then within 1 hour of diagnosis, you want to ensure that your antibiotic is given. If there's no septic shock, ensure that antibiotic goes within 3 hours. And now this will call to question how available the antibiotics are. If you're in a facility where maybe patients may have to purchase antimicrobials out of pocket, then we have to think of stocking some antibiotics in our emergency cupboard so that if you have a patient with sepsis or septic shock, you can make use of those emergency medications and then the patient can replace them subsequently. Now, what route would you want to use? So, IV preferred. In emergency situation, if that is not available, your intraosseous route. Okay. Sometimes you may be restricted. You're unable to get an IV access. You may not be competent enough to put in an intraosseous. Don't forget, IM route can be given for some antibiotics. And then also, of course, if that is also not possible, you would be looking at giving oral antibiotic. Of course, in the septic patient, remember, absorption may be an issue. So there may be delayed onset in your medication. But of course, that may be better than no antibiotic at all for the patient. So, how do I safely administer fluid therapy? At this point, I would like to hear a few comments from us. What strategies do we use in our various facilities in deciding who needs fluid and how much fluid to give and what fluid to even give? Any comments?
Feel free to write in the chat again. Okay, there's no
Any comments in the chat so far?
Yes. We give fluids according to kilo body weight. The answer.
Okay. Any additional comments? What is the usual fluid that we give as fluid bolus in our septic patients? What options are available in our various facilities?
We give Namosaline 20 ml per kg body weight within 1 hour.
Sarah, can you please repeat a bit louder?
Namosaline 20 ml per kg body weight within 1 hour. 30 to 1 hour time. 30 minutes to 1 hour.
Thank you very much, Sarah. So I would like to throw a bit of light on what happens in the patient's blood vessel when they come in with sepsis. So the top picture, let me look for my pointer. Good. I hope you can see my laser pointer. So the picture labeled A shows a normal, healthy endothelium. And we can see all these hair-like projections. Now, these are what we call the endothelial glycocalyx. Now, these act like a barrier that prevents proteins and fluid from leaking out of the vessels outside into the interstitial space. Now, the picture below is a patient with sepsis who has a damaged glycocalyx. So as you can see, you have very few hair-like structures in the second image as I'm pointing. And in your septic patients, they are going to leak a lot of fluid. They are going to leak a lot of protein into their interstitium. So remember, as we give them resuscitation fluid, there is always that increased risk that they might go into fluid overload. So you need to pay very close attention when you have to initiate fluid for those patients. Having said that, now two strategies exist whenever you have to give fluid bolus for your patient who has come in septic shock. So we have the restrictive strategy and then we have the liberal strategy. So now I have looked at the surviving sepsis guidelines. I've looked at the FISH trial, which is a very important landmark study that has ultimately guided how we look at fluid therapy in critically ill children. And then also combining that with the Pediatric Acute Lung Injury Consensus Conference guidelines, which looked at pediatric ARDS and their recommendations when it comes to fluid therapy as well. So a lot of us are tilting more towards the restrictive approach, which looks at smaller fluid aliquots over a relatively longer duration. So previously, we used to say fill the tank. We used to say that give as much fluid. So we would give 20 mils per kg. We keep repeating until we are getting to 60 mils per kg before we start deciding whether or not to add on vasopressor. Now, it's been noted that in critically ill children, especially in African children, a lot of fluid boluses can actually result in poor outcome or can result in harm in these patients. And just as I've shown you, it increases their risk for fluid overload, and we know that that ultimately increases your length of hospital stay. If they're in the ICU, you may end up increasing their number of ventilated days. And then, of course, the longer you stay in ICU, the higher your risk of picking up hospital-acquired infection as well. So we would typically go with 5 to 10 mils per kg of fluid over about 15 to 20 minutes. You can go up to about 30 minutes. Okay, as opposed to the previous teaching, which goes with 20 mils per kg of fluid infused rapidly over about 5 to 10 minutes. Now, if you are in a low middle income country or in a resource limited setting, you would want to stick with the restrictive approach. Now, the reason why the liberal strategy was proposed, because most of the recommendations were based on high income countries or in settings where there are adequate ICU resources. And therefore, even if you're tipping a child in fluid overload, you have ICU to support. You can adequately ventilate these patients and take over the respiration. By an our setting, ICU is limited, so you are better off doing the restrictive approach. Now, the caution is you must carefully monitor these patients when you're giving small aliquots of fluid. Otherwise, you may end up under correcting their hypovolemia. Okay, and then the reverse is also true. If you're doing the liberal approach, you stand the risk of overcorrecting or overhydrating the patient. Now, with regards to the choice of fluid, now we're tilting towards balanced solution. The commonest balanced solution we have in our setting is the lactated ringes or ringes lactate. Okay, and there's been studies that have compared ringes lactate or balanced solution as against normal saline. So I would want to say 0.9% saline. I don't want to call it normal saline because it's abnormal. It has about 154 millimoles per liter of chloride, which is way higher than what we have in our blood. And therefore, if you put a patient on very high load of chloride, then there's a risk that you might tilt them into chloride-driven metabolic acidosis, and that may actually worsen patients' outcome. Now, I just want to focus on two main studies, the SALTED trial and the SMART trial. Now, the SALTED trial was done in non-critically ill patients, and the conclusion was there was no difference in hospital-free days between the control and then the study group. Okay. So if your patient already had pre-existing AKI, then they benefited more from balanced crystalloid. Now, for the SMART trial, that occurred in critically ill patients. Of course, they were adults, but most of our studies are being extrapolated in pediatric patients. Now, the conclusion was if you used a balanced solution like Ringer's lactate, then you minimize the risk of your patient having a major advanced kidney event within 30 days of treatment. Okay, as opposed to if you use normal saline. In effect, what they found was most of the patients, or a significant number of patients who received normal saline as bolus had higher incidence of AKI, had higher incidence of metabolic acidosis, and they had higher requirements for renal replacement therapy. So there's one thing we need to take note. If you have the option to choose between a balanced solution like Ringer's and then normal saline, please go for Ringer's lactate. Unless, of course, you have a patient where you're already worried about hyperkalemia, and therefore you may probably want to go the route of normal saline. So once you give fluid, it's important to monitor the response. Now you're looking at whether or not your patient had a positive response to your fluid therapy by assessing what the heart rate is. Did your heart rate improve? Is your pulse volume stronger? Is the cup refill time reduced? Are your saturations improving? If I'm treating my patient right, then the sensorium should also improve, and I should be seeing improvement in the urine output for the patient, which means that once you think about putting IV fluid in a patient, you should have a means to monitor the output. Also, you are monitoring for evidence of fluid overload. So you're looking at whether or not your patient has started developing signs of edema. Is there hepatomegaly? Has the patient had bibasal crepitations? Are there worsening in your parameters of shock? So if these are the findings in your patient, then you may want to be cautious with your fluid. Now, increasingly, the role of bedside ultrasound has become important. And by so doing, it's interesting. A lot of cases that we've thought, oh, this patient needed fluid. You do your ultrasound, bedside ultrasound for the patient, and you realize that this patient may actually have their intravascular volume already filled. And you assess the contractility. Some of them may actually have more of poor cardiac contractility as opposed to really needing fluid. So you really need to be able to determine who is likely a fluid responder and who is likely going to be a fluid non-responder. So remember, it's always a juggle. It's difficult to tell who is going to respond to your fluid, but at least checking for some of these things of fluid overload and then using ultrasound is able to assist us plan or guide our fluid management better. So remember that if your patient is not in shock, please, please, please do not routinely give fluid boluses. Okay, because ultimately that has been noted to reduce survival in the patient, has been noted to increase risk of mortality. Now, this a nice infographic just summarizing liberal versus restrictive approach, and it also has a small comment on fluid responders and fluid non-responders. So why is it that some patients are needing less fluid and we have to be cautious? So remember that your fluid hemodynamics keep changing, okay? And your ability to improve your cardiac output with fluid, your best shot is within the first 60 minutes. The more you give fluids, your patient may actually transition or could transition from a fluid responder to a fluid non-responder. Now, it's always like a flip of a coin. So there's always a 50% chance that your patient may or may not respond to the fluid. And I've already mentioned that 95% of patients who were initially fluid responsive have been found that within 8 hours can actually progress to become fluid non-responsive. Okay. And then also, like I said, sometimes it's very, very difficult to actually tell who would respond and who will not respond. So you want to be cautious and monitor your patient. And remember, your IV fluid should be treated as a drug. They are not without side effects. So you always need to monitor your patient for evidence of fluid overload. So our next learning objective, when do I initiate vasopressor and which is appropriate? So always remember that your patient with sepsis who has progressed to septic shock doesn't only have issues with vasodilatation and increased vascular permeability. Some, may actually be coming in with sepsis-associated myocardial dysfunction, in that they may progress from vasodilation and warm shock into increased vascular permeability where they are having endothelial dysfunction. And you can actually end up with not only edema in other tissues, but edema of your myocardium. And once the myocardium is edematous, it becomes less contractile. Also, your adrenal receptors are downregulated in sepsis and they become less responsive to your circulating catecholamines. Your myocytes are also injured either by increasing amount of lactate by your reactive nitrogen and oxygen species, as well as bacterial particles. Sad enough, damage-associated molecular patterns, which are damaged cells from the host or from the child, may also trigger more inflammation and injury to your myocytes. And then, of course, your patient may then progress into cold shock and then subsequently into multi-organ failure or multi-organ dysfunction. So it is important to always ask the question, why is my patient not responding to fluid? And for the restrictive approach, we say that if you're nearing 30 to 40 mils per kg of fluid, you always have to think of coming in early with your vasopressor. Or like I did mention, if your patient is beginning to show early signs of fluid overload, then you have to slow down with your fluid and think more of vasopressors. Now, remember this equation. It is the oxygen delivery equation. Now, the parameter in red is your oxygen content. And then the parameter in blue is your cardiac output. And we also know that your blood pressure is dependent on your cardiac output and your total peripheral resistance. If we further break apart your cardiac output, it's your stroke volume times your heart rate. So we've done a good job providing some oxygen or some respiratory support to the patient to try and push up their oxygen content. You have tried to improve cardiac output by improving stroke volume, but that is not working. You have to target trying to titrate your total peripheral resistance, and that is where your vasopressors come in handy. Now, options available to us, you have your noradrenaline and adrenaline. Okay, and to some extent, dopamine would give you some vasopressor activity. Now, dobutamine is more of an inotrope and an inodilator. Okay, so for patients who have clear evidence of myocardial dysfunction, okay, and they are also vasoconstricted, which means they are already in cold shock and maintaining their blood pressure, you can come in with dobutamine. So if the patient has warm shock, your first choice, which is usually what we do in our setting, is to go with noradrenaline. Okay, if your patient has cold shock, adrenaline. If your patient has myocardial dysfunction, dobutamine. And in some settings, if mirinone is available, you could go with mirinone, which is a phosphodiesterase inhibitor. Of course, if the patient is hypotensive or normotensive, adrenaline, noradrenaline would come in. You'll be cautious with inodilators like dobutamine, as they can further drop your blood pressure. And of course, all of these things that we are talking about is dependent on availability as well. So as it stands now, per the surviving sepsis guideline, WHO, and other protocols, there's not strong enough evidence to recommend one over the other. However, one thing we know is that these other options are way better compared to dopamine. So in a lot of settings, you realize that dopamine has been relegated to the background. And in some settings, they restrict it to the rural or peripheral facilities where they may probably not have ready access to noradrenaline, adrenaline, and dobutamine. And now once you put your patient on it, you must have a goal. And what are our goals? You want to see reversal of your parameters of shock. You want to see improvement in the sensorium of your patient. You want to see improvement in urine output. And if you are monitoring lactate, you want to also see decline in your lactate level. So starting the patient on the vasopressor is not enough, but your ability to titrate it. So I always tell people, once you have the patient on the vasopressor, you need to assess the patient every 10 to 15 minutes and titrate your vasopressor to the desired response. So you don't leave the patient at the baseline of, let's say, 1 ml per hour, which for our preparation, let's say you're starting at 0.02 microgram per kilogram per minute of adrenaline. And then for 6 hours, the patient is on the same dose and yet still in shock. Every 15 minutes, you want to be sure that you are titrating your vasopressors and taking a decision whether or not you need to come in with a second vasopressor. So within 6 hours, you should have optimized your vasopressors for the patient per the surviving sepsis guidelines. Now, what happens when all your superheroes are not working? So you have your epinephrine, you have norepinephrine, you have dobutamine. Your patient is on adequate doses of your vasopressors or your inotrope, but it's still not working. At that point, you have to think of the possibility of your patient having down regulation of your adrenal receptors, or there's blunting of the response of the receptors to the catecholamines that you're giving. And sometimes as well, you want to dampen the inflammatory response that is propagating all this sepsis process. And then the last thing you need to think about is, does this patient have some adrenal insufficiency? And that is probably contributing to why the patient is persistently in shock and refractory to my vasopressors. Now, remember, back again to our case, our patient was in shock, was hypoglycemic. Now, we've been treating this patient, we've treated hypoglycemia. Now, that would probably heighten our suspicion of the presence of adrenal insufficiency in this patient, and therefore you would want to come in with your steroid. And the commonest one that would give is hydrocortisone. Now, there's no rule for routinely starting hydrocortisone, so you have to really tailor it to the patient's need. Okay. The next thing you want to do is to provide supportive therapy for your patient. As we have it, it is really dependent on what organ dysfunction the patient is presenting with. Okay, so it's also important to carry out your secondary survey, and that is what is going to help us pick up these dysfunctions. And this will definitely direct what investigations you will do for your patient. Now, you use the head-to-toe approach. So when you take the CNS, is the patient encephalopathic? Is the patient having seizures? You need to address all these things, okay? Is the patient hypoglycemic? You need to ensure that the patient has euglycemia. Is the patient in respiratory distress or in respiratory failure? That is where your respiratory support also comes in. Whether invasive or non-invasive, we know that it also minimizes the work of breathing for the patient. And once you minimize the work of breathing, it overall reduces the metabolic demand on the body. And that helps to improve the outcome for the patient. Does your patient have any abnormalities in terms of the hematologic system? If the patient is anemic, then you'll be guided by the transfusion guidelines as per the TAXI guideline. And that suggests that if your patient's HB is less than 7, you would want to transfuse the patient. If the patient has an HB between 7 and 10, then we say that what? You use your clinical judgment to decide if the patient should be transfused or not. Also, you need to assess if the patient is coagulopathic. If the patient has DIC, then please, you need to decide, apart from giving red cell transfusion, do I need to give this patient platelet concentrate? Do I need to give the patient FFPs? And if you have cryoprecipitate in your facility, then you may want to think of giving that as well. Sometimes you may have to even throw in tranexamic acid to aid the patient reverse their coagulopathy. But also remember that not every patient with DIC would go the route of the bleeding. Some may actually be coagulating more than bleeding. And in those instances, you really, really need to tailor your treatment. So if the patient has evidence of thrombosis or has thromboembolic events, then you may want to consider initiating thrombolytic therapy for the patient. Now, GI dysfunction is also a major concern in these patients. And a lot of the times you have to pay attention to bowel function. They may have ileus, and if you miss it, that may contribute to feeding intolerance, and then your patient can aspirate, and that may end up worsening your outcome. So the other thing closely related to your GIT is your biliary, hepatic and biliary system. And you definitely need to support the liver if the patient has evidence of liver failure. So any medications that potentially can worsen liver injury, or paracetamol, ceftriaxone, for instance, that has the possibility of causing biliary slashing and worsening cholestasis, you'd be thinking about all these things. And then, of course, if your patient has acute kidney injury, you address the cause. If it's pre-renal, we improve volume. If it's intrinsic renal, established renal, then you may probably want to come in with diuretic therapy. And if that is not working, you may want to speak to your renal team and see if they can help you with renal replacement therapy. Okay. And then another important thing that we always need to focus on is source control. So if we do all these beautiful interventions for our patients, and yet we miss the source of the infection or the source of sepsis, then we might just be pouring water into a basket. All our efforts may go down the drain. So it's always important to ask ourselves, what are the potential sources of infection? So it could be infections in the various tissues. It could be indwelling devices in the patient. So you need to look at that, okay? So now back to our index case. What do we think could be the likely source of infection in our patient? Now, I've told you that the patient had a distended tense abdomen. So definitely that is a potential source. And the patient has had surgery or has had surgical intervention. So the intussusception in itself has the potential to compromise bowel integrity and be a focus for infection. And now with resection and anastomosis, there's a possibility that there could be infection, deep surgical site infection, there could be anastomotic leak or a complete breakdown. So definitely that abdomen doesn't look benign, and we definitely need to have a look at it. So for our source control for this patient, we need to get a bedside ultrasound. If you have complex fluid collection in the abdomen, then definitely you may be looking at abscess in the abdomen, and it will need surgical drain. Okay, so that will be the appropriate intervention for our index patient. And in all of these, you need to clearly document and communicate with your colleagues. So we always use the SBAR approach, which is the situation, the background of the patient, your assessment of the patient, and recommendation. If you use this tool to report your findings, it helps you be structured in your communication with other colleagues so that you can actually hand over relevant details about the patient. Now, you also need to record critical actions that you've taken for the patient, and you need to document the time. including whatever recommendations you're making for the patient. And then the tool or the guiding principle, always reassess your patient. Always reassess your patient, because a patient who is improving could potentially deteriorate. So if we take our eyes off the ball, we could actually lose this fight. So that is very, very key. And the question is, what are you monitoring? So you can monitor flow. So things about flow, you're looking at capillary fill, you're looking at pulse volume, you're looking at the extremities. Okay. Then you have the pressure monitoring guides. So your blood pressure, okay, and closely related to that, you can also look at if you have the ability to do invasive monitoring, you do that. Other places may do central venous pressure monitoring. Okay, but of course, your blood pressure should be the basic. And then monitoring the output or the response to your intervention. So if the patient is adequately perfused, what will be the outcome? There should be improvement in saturation, heart rate should be coming down, urine output, sensorium. So these are the things that you're looking at. Of course, lactate, if you have the facility to monitor that as well. Okay. So at this point, I would like to pause for questions and contributions. Thank you.
Thank you so much, Eugene. That was really insightful, and we've seen a lot of participants, more than 100. So yes, we have 2 questions for the chat, and then I will let the people who want to ask further question ask them. So we have one question from Richard. When you talked about the respiratory distress, is there a target SpO2 you have to achieve because in concern of the oxygen delivery? So would you say you have to achieve above 90%, or would you determine that if you have no blood gas you can have, for example?
Okay, thank you. So if you are managing the patient, your target saturation is always above 92%. And that is usually safe for a lot of the patients, and also safe for us to be a bit comfortable. And now that is dependent on if the patient doesn't have ARDS. Now, if the patient progresses into ARDS or the patient's lungs are very, very sick, then sometimes you may actually have to lower your saturation expectations. So in those instances, we could go as low as 88 to 92% for our saturation target. But for most of your patients, you want to keep their saturation above 92. The reason why I made the comment about always trying to calculate your SF ratio is because using the saturation alone doesn't tell the whole story. If I'm on 30% FiO2 at 92 SpO2, I am way better compared to someone on FiO2 of 80 and the same 92%. So that just gives you a fair idea of how much resources we are expending to achieve that target, so that it warns you ahead of time between the 2 patients who is sicker. Thank you very much, Richard, for that question.
Thank you very much. We have another question from Mildred. The question is, what is the goal for middle artery pressure that we should target when giving fluid therapy? I guess this is depending from the age, but maybe you can complete that.
Yes, so in pediatrics, it becomes very difficult to give you an absolute value. Okay, but we work with BP centiles in pediatrics. So I would say that I want to keep the patient's BP centile between the 5th and the 50th for their age, height, and sex. Okay, so that number actually varies depending on the age, the sex, and then the height of the patient. So it will be very, very difficult. But they are like guides to actually direct us, or guide us. So if you look at the Phoenix sepsis score, there is a mean blood pressure guide or target for various age groups. So you can also use that as a guide as well. Yeah.
And you can find it online quite easily, yes. That's okay. Thank you so much. And we have another question from Gemishu Ede. The question, when do we de-escalate the inotropes what are the optimal titration rates and monitoring frequencies while de-escalating the inotropes?
Okay. So once you have a positive response to your vasopressors, you would also not want to titrate too quickly. So typically, you want your patient to be stable for 12 hours at least before you think of coming down. Unless, of course, your patient's mean blood pressure, for instance, is way over what your targets are. For instance, if my patient is on vasopressors is in hypertensive range, obviously it tells me I'm doing too much. So with that, it's not because necessarily of good response, it's just because my intervention is way excessive. So like I said, you have your goals for the patient. So what is my cup refill? What is my extremities feeling like? What is my pulse volume looking like? Is my patient producing urine? Is the sensorium improving? Am I achieving my target blood pressure between the 5th and the 50th centile for the age? If the question is yes, and your patient is heading in the right direction, then you would probably want to maintain them for about 12 hours. And then you can begin de-escalating. Now, when you're de-escalating, you'd also want to be cautious. So there is no hard and fast rule, and there are no clear guidelines as to how to go about it. But I always like to go with 4-hourly titration of my vasopressors. So every 4 hours, and you would always want to go with the vasopressor that was added on last, or based on additional information, if it directs you as to whether the patient is vasodilated. For instance, if my patient was more vasodilated, they had a wide pulse pressure, then definitely I'm likely to maintain noradrenaline as opposed to adrenaline if the patient is on both. If the patient has more cardiovascular dysfunction or myocardial dysfunction, I'm likely to maintain my dobutamine or adrenaline as opposed to the noradrenaline. Okay, so there are nuances as to how to wean them. And then, like I said, every 4 hours, you want to step down at a rate of 0.02 mics per kg per minute if you're doing noradrenaline or adrenaline. And if you're doing dobutamine, you want to be stepping down at a rate of about 2 micrograms per kilogram per minute. Now, based on our infusion rates that we use here, that would range like usually about 1 ml per hour. Okay, so you can have a strategy. I'm reducing at 1 ml per hour at the doses that are indicated, and then you keep reassessing your patient. If your patient's parameters decline or retrogress, then it means that the patient is not ready at that point. You just go back to the initial rate that the patient was on. I hope that answers your question.
Thank you so much. Yes, we actually had quite the same question in regard of escalation, and I guess the answer is quite similar, right? So you see
Yes.
which reason you have. Is it a cardiac dysfunction? Is it a peripheral dysfunction? And then you will escalate or de-escalate. Yeah, exactly the same, right? What would you say?
Yeah.
Etienne?
Yeah, so for escalation, the rate of escalation is actually more rapid in terms of the rate of de-escalation. So once we are escalating, remember we have a fixed target. We want to titrate and reach our goals within 6 hours of initiating the vasopressor. So every 15 minutes, you would be reassessing and titrating up. However, when the patient is stabilized and you're de-escalating, you want them to adjust to the physiology, okay, before you actually rapidly wean their vasopressor off. So like I said, escalation is more rapid. Every 15 minutes should be titrating, and de-escalation is slower. Okay, sometimes you can do every 2 hours or every 4 hours. Okay, it depends on your monitoring. So if you don't have the tools or the human resource to monitor this patient quite frequently, then you are better off probably slowing down and making sure that whatever time you give to yourself, you are there to reassess the patient. And whenever you make changes, don't just walk away from the patient as well. You have to stay with the patient, monitor the patient for about 15 minutes and see what the response of your de-escalation is before you move away from the patient. Thank you.
That's a really good point, yes. Yeah, we have two further questions. I guess we will stop with the question, if that's okay. So we have Elikana who is asking for a case. If the child has septic shock due to diarrhea and have anemia in failure with acute renal failure and the child is dehydrated, which resuscitation protocol can be used? So I guess this is, you continue with A, B, C, D, but I let you the word.
Yes. So, I mean, there is a patient that clearly has volume loss. So if you have a history of volume loss, okay, yes, it's likely that patient is going to be fluid responsive. So your goal for that patient is going to be more fluid. However, remember, not every case of diarrhea and vomiting is clear-cut hypovolemic shock. We know that some of them may actually come with a mixed picture. There may be a component of hypovolemia, but then again, there may be some septic shock ongoing. So even for these patients, if you're going beyond 40 to 60 mils per kg of fluid, you still have to think of coming in early with inotrop. Reason being that it aids you hold your volume in the intravascular space, and ultimately it reduces the overall amount of fluid that these patients need as compared to just coming in with fluid. And remember, as I mentioned to you, any septic patient has, leaky vessels, and all your fluid that you're giving, potentially a chunk of it will be lost in an interstitial space, and really takes a lot of time and effort by the body to try and rid itself from this fluid that has gone into the interstitial space. The other thing, so for that patient, most likely the cause of the AKI is going to be pre-renal, and therefore optimizing your circulation in that aspect is going to improve the acute kidney injury. And then the last bit I want to add is that for fluid therapy in your critically ill children, always remember fluid therapy is divided into your resuscitation fluid, replacement fluid, maintenance fluid, and then correction of ongoing losses. So you always have to decide at which point the patient is. So whilst our fluid policies are addressing resuscitation and trying to optimize perfusion, you still need to evaluate this patient and decide, is this patient dehydrated? And you need to correct dehydration. Otherwise, you still just be chasing your tail and the patient will keep going back in shock. Thank you very much.
Thank you very much, Eugene. Can we ask a last question from John Adabi?
Definitely.
That would be the last, if it's okay for you. So yes, the question from John is, could we comment on the use of 5% dextrose water for resuscitation and maintenance? So that was a bit of your topic now.
Okay. So one, when selecting a fluid for resuscitation, the first thing you have to satisfy is that it should be an isotonic fluid. Now, plain dextrose fluids typically are hypotonic. Even if the dextrose component makes it isotonic, your body is going to metabolize the dextrose or the glucose, and you just be left with a lot of free water in circulation. That is going to further dilute, and that increases the patient's risk for fluid overload and pulmonary edema. So I would suggest not using plain dextrose as fluid resuscitation. The only time we would be using it is if we are correcting hypoglycemia, like the patient we had. Okay.
Thank you so much. And maybe my question, would you use colloids on septic patients?
Okay.
Krista?
So,
Exactly, yes.
yeah, I mean, in the event of sepsis, yes, I mean, there is always that caution with colloids. Okay. And for the same reason, if we go back to this diagram where I showed the endothelial glycocalyx. So in the septic patients, use of colloids as compared to crystalloids have been associated with higher risk of fluid overload, and also increases their risk for longer stay, especially in ICU. Okay, and where's my diagram? A moment. Okay. Yes, for this very reason. So as we can see in the second diagram, there is increased leak for plasma protein. So given colloids is going to result in all these proteins getting into the interstitium. And it will be very difficult to actually move them back into the vessels and rid the body of them as compared to the crystalloids. However, in certain instances like burns and sometimes in traumatic brain injury, there may be a place for colloids. But in septic patients, sometimes you want to be cautious. So until we have a lot of strong evidence to recommend its routine use, most of the guidelines recommend going with the crystalloid.
Yeah, thank you very much.
Thank you.
Thank you. Okay, I guess okay, so the last question is it better to use Ringer as plasma expander? You say that it's better to use plasma expander, that right? Yes, okay.
So a balanced solution. So ringers, or if you have plasma light in your facility, yes. So these are two examples of balanced solutions. However, like I said, if you don't have these and all you have is normal saline, don't be waiting for ringers. Use the normal saline. Thank you very much.
Thank you very, very much, Eugene. As you've seen, there were a lot of participants. We should extend the numbers of participants again because, yeah, a lot of people joined, and I guess, yeah, your lecture was really on point, and I guess can be used tomorrow in the clinical practice. So thank you so much.